It's now my pleasure to introduce our speaker, Trish Tulloch. Trish, I'll now hand it over to you.
Oh, thank you, Rich, and welcome, everyone. I'm delighted to be with you for the 4th webinar. This will be on training and testing, and I know that all of you have really been involved with that, with your council and coalitions in Florida. We're actually delighted to be with you. Now, this recording, of course, this program is being recorded and is also being archived with the other 3 programs. So you will be able to have access to those. Now, I want to start with answering the webinar 3 questions. As some of you that participated with that, I tried to answer them during the program and did receive one afterwards. I know this is the last program, so if you have any questions that come up after this program and they aren't answered during and the program is really terminated, feel free to contact me, Tricia. And on the bottom of that first slide is our email, rbc@netstep.net, because I'd be delighted to respond to any questions that you have. So during webinar number 3, which we talked about communication plans then, these were some of the questions. How does an organization measure their effectiveness of their communication plan? And what groups are you talking about for mass notification systems in an agency? And that was, of course, a smaller entity. So communication plans, as we all know, are important to be effective. So we would expect in your communication plan, an emergency preparedness plan, you would be identifying specifically the who, what, where, and how. So who is the individual, your incident commander or commander, responsible to consolidate that communication and, of course, confirm distribution and frequency. Of course, that commander has a team that's doing that and going through them. Our goals for the communication plan are accurate and timely communication. So evaluation can be tricky. And I know that some of you or all of you have participated in drills or real events and been a participant in your after-action reports. Communication seems to be one of the bigger challenges, particularly when there's a disruption in power or infrastructure, and we've experienced them in Florida, Texas, Puerto Rico, and many events. So your evaluation is consistent, frequent messaging, multi-tiered, and a continuous feedback loop. So what would that continuous feedback loop look like for all of you? Of course, depending on your size, it's certainly the staff. If you have staff in the field or patients or caregivers or other branches or entities that you work with, the communication that they're providing back to you. They're calling in with questions, they don't understand the message, they don't feel like they're updated. That continuous feedback loop is really critical. Now, some of you that are very large, and of course many of our large entities also have an arm of really keeping an eye current on the media as well as social media. So our Facebook, our websites, our Twitter and texting, because that's another way to get continuous feedback during an event. In your after-action reports, of course, in your agencies and for Florida, people were very good about saying and discussing their difficulties with trying to reach people. They felt there were gaps and information gaps and long periods of time without information within their agency. So that's something that you would want to identify in your plan, that frequency of communication. Now, the bottom line is if we don't consistently communicate with our stakeholders, internal and external, the issue becomes that we just as people tend to fill in the gaps. And I see that often even in organizations where coordinators, supervisors, managers may be on the phone calling down to staff in the field or patients and families or vendors or other external folks, and of course their messages are different or inconsistent, and that of course is a huge priority that you want to ensure. Frequent, consistent, updated messaging, and if there is no update, then you want to repeat that consistent messaging. I think the digital era has had a huge impact in transforming crisis management, and of course that can go two ways, as we know. The second thing, of course, on communication plans is your mass notification groups. And we recommend that you would have that in place. And I know many of you already have it in your entity, but you'll already have templates and pre-groups established in your mass notification, internal and external. And I listed some on this slide. You know, your leadership might be different for all staff and your vendors and patient caregivers and then your other external stakeholders, so that you're sending out that template information on a regular basis, and you just filling in and updating that information to those groups. The bottom line is that all stakeholders, internal and external, need to have that consistent, accurate communication on a frequent basis from you, because rumor control is vital, and rumor control can be very harmful to all of us, as we know. So it's keeping your finger on the pulse of what's happening, and as soon as you have it, update it within your incident command and with your commander, rewriting those messages and then getting that communication out. When things are bogged down in the communication plan, we often find that it's just the slow messaging and that inconsistent messaging and getting out of that command system out to everybody in the group, the operations group, and out to the staff and patients and families. The other question that came up is, would these be archived? Yes, they are. Your council and coalitions are archiving these. I understand they'll be on the website by July 1st, and you'll have access to them. The slides and the tools will be archived with these 4 outpatient programs as well. And then the other question that always seems to come up is about policy and procedures for the 1135 waivers, of course, and how does that affect us? If we just close, we're an outpatient therapy or rehab center, or ambulatory surgery center, we just closed. What does this have to do with us? And of course, the waivers, and you can find a lot of information on the 1135 waivers right on the cms.gov website, but they're specific to your regulations and standards. And so when there's a public declaration, an emergency declaration for a region or multi-jurisdictional region, or the entire state as it was for Irma, then of course that goes through the channels in your CMS regional offices, which are really located in Atlanta, of course, requests, and the waivers are issued. So the waivers are specific to your standards and regulations. There's a good document on the cms.gov website on the waivers, the definition of waivers, what it means, and how it applies to you as an entity. So if you want further information, I would recommend that you go on and do that. But it means that they can waive some timeliness, some billing issues, some HIPAA, standards, and out-of-network providers. So they can provide different regulations. So, for example, for home health, they can, of course, allow you to provide services in a shelter, even if it's not within your region that you're certified or licensed for. They can modify your clinical documentation and suspend other further requirements, such as transition requirements to meet quality and payment timeliness requirements, and the same for hospice in terms of plan of care. So the 1135s would be specific to the services that you provide. So for the training and testing portion, then, of course, all healthcare providers that bill Medicare or Medicaid and fall under these emergency preparedness are required to train and orient to staff and then test staff. And very specifically for each provider, the interpretive guidelines are a great place, Appendix Z, to reference for your specific organization because we're a very diverse group. So we want to look then at the core training and testing requirements. So we'll do that first as an overview, then drill down on the types and the documentation and the after-action reports, and then look at some tips and tools. And the tools that I gave you are some sample that you may be able to modify and use for yourself. Of course, on your Coalition Council website, you have excellent information for training and testing, so I would encourage you all to take a look at that information as well. Upcoming events, as well as sample or templates for your after-action reports. So this is the fourth provision of the final rule specific to training and testing. So let's start with the core requirements. Every outpatient healthcare provider needs to provide specific training and initial training on policies and procedures, and then conduct those drills and exercises. So what are the core elements for training and testing? Now, we all know that on an annual basis, you're performing your HVA and revising your plan and policies, including your communication plan. So your training and testing is going to be based on those revised policies and procedures. So you'll have initial, and then you're going to have annual training and testing. Some of you or most of you have mandatory annual training, and so we would recommend that you roll your emergency preparedness updates specific to the roles and responsibilities of the people that you're training right into your annual mandatory updates. So the training program would be for new and existing, of course, any contract staff and volunteer, and the requirement has to be role specific. So your clinical staff training will be different than the leadership, will be different than your office or your support staff. You are required to maintain documentation of that initial and annual training, and you're also required to demonstrate staff knowledge of the emergency preparedness. So the really interpretive guidelines give excellent examples for this. Now, the overview or the core requirements then for testing is that you conduct exercises to test your plan at least annually, and we all know that we need to participate in a full-scale exercise, which is community-based, so we'll drill down on that a bit. And that the second one may be another community or actual event or a tabletop exercise. Just to note, of course, and we all know this in the final rule, that if you as a provider actually experience an emergency that requires activation of your emergency plan, then that actually fulfills the full-scale community exercise for that year. So, of course, many of you with your hurricanes and tropical storms and flooding events where you've activated your emergency plan, that then qualifies for that full-scale community exercise. So more on the core training and testing requirements. So they have to be reviewed and updated annually. It has to reflect your annual HVA. And then, of course, you want to be sure that training and testing really requires communication internally and externally and is specific to your regulations and standards. So that bullet number 3, for example, if you're a home health agency or a PACE, then you would be required to take a look at testing your patient tracking system and your staff tracking system. And of course, we've talked about that before, but you would have a policy on that. And then, of course, you would be testing that during your exercises. If you're a provider with multiple locations, then you really want to perform your training and testing at those specific sites. Unless they're close together, you want to be sure that you're reflecting the environment and the conditions in multiple sites. So what are the training specifics? So let's drill down. Your initial orientation, which you've all done, is really Emergency Preparedness 101. What is it? Why is it important? What are the policies? And how does it apply to my roles and responsibilities, specific to what I do within your agency? So all of you then have built that into your orientation programs. When you're onboarding your new staff, or for hospice, for example, new volunteers, you would be including that EP 101 course. The training needs to be specific for the roles. So for all staff, contract staff, and volunteers, what are their roles? And then I broke it out as leadership, clinical staff, and office and support staff. So you'll be breaking down that training and then having them participate in an interactive event. So you're really assessing, are they understanding their roles and responsibilities? I think, and I know that many of you find this at times, that during a real event, people absolutely stop, don't they? They go very slow. They don't know what to do. They don't know where to turn. Everybody's used to the fire drills. Everybody's used to the predictable events. But the unpredictable events sometimes throw folks off in an agency. And those are the ones really that you want to train and exercise and test on as well. So for your leadership, your specific role training, there are many places for that. Certainly your coalition has excellent training opportunities. The FEMA.gov, I will say, as well as ASPR, Tracy, I would look at some of those websites and courses because they provide excellent information, particularly on the ICS and collaborating with your partners. For clinical staff, you're going to want to be very specific about their role. So, for example, for people that have folks in this field, so our PACE, our home health, our hospice, folks who are out in the field and an event occurs, they need to know right away, okay, my role when the event occurs, specific to me, is I am supposed to call in every half hour or hour to tell them my location and what my plan is. What have I rescheduled my visits? Have I had to change because of flooding or evacuation? So they need to know, how does the emergency event affect their specific role? And for office support staff, of course, if they're part of deploying that messaging and prioritizing patients and messaging, they need specific training on who they're going to hear from. Who do they check with? And if they have questions, where do they go? And how do they drill down? Do they get their call lists, and do they start making lists with message number 1? And what happens if the message updates? How do I prioritize staff and patients and families at that time? I know that all of you know that all of us as adult learners, we can be a tough group to work with. And so the groups, when you get together with your exercises or tabletops, for example, being interactive, practicing in your breakout groups, so you're actually collaborating together and learning each other's roles and responsibilities, doing that 360 on an event in an interactive program, less stressful, more learning occurs, and I think it's an excellent way to do it. And you've all participated in those. Of course, some of the strategies for your training and testing would be to partner with presentations with your coalition members. So I have found when we've included, the coalition or other home care agencies or other dialysis centers, the police, OEM, DOH, those partners do an excellent job when they're part of our process either for a tabletop exercise or for planning the exercise or even performing an HVA update. It really helps to do that. And incorporating staff members and champions in the group. Now also incorporating people from team meetings and staff meetings and special events. So I find in the training portions, both on orientation and your annual updates, be sure to emphasize personal emergency preparedness. I can't emphasize that enough because all of us have been in emergencies that have been unplanned or unpredictable, and we have found that our whole staffing configuration changes because our staff don't have a solid personal emergency plan. We find when we work with staff and help them consolidate that so their family, their children, their parents, their pets, significant others are taken care of, that they actually do better with anticipating their staffing capabilities for you before, during, and after an emergency. So for the training and testing, that core component of really contacting and documenting that you've contacted your local, your regional partners and officials to participate in those community events is really critical. CMS will be looking for that documentation. Now, how do you demonstrate knowledge? How do staff? You know, when surveyors come on site, they'll be interviewing staff, but it really helps that you have documentation of that specific training and testing, and that will be reviewed by a surveyor on site as well. They'll be looking for goals and objectives and case studies and your discussion for Q&As. But what's also helpful is that you include some documentation in their personnel files. And so that tool number 1 that I gave you was an example. This was for a home care agency to demonstrate knowledge of the policies and procedures. We've used this with many entities and just changed the core elements between leadership and clinical staff and office and support staff. We've changed the elements. And then, of course, we've done group exercises and training, but we've had them discuss those elements prior so that we could document in their personnel files, both initially and then on an annual update. Of course, you would change it for your annual updates, but that they understand their roles and responsibilities during an emergency event. Now, that requirement is not required. You'll have to have some documentation in the personnel file, and I know that you all have different, both paper and electronic formats to follow for that. The other considerations for training, of course, is be sure to identify specific learning outcomes that they're measurable, and having program evaluations and staff feedback is really helpful. We all know that. I find that other than including our community partners, because they do a fabulous job in the presentations, but using videos and group training modules is very helpful. And of course, you can find several videos online. Some of you probably already use them, and your coalition and your other partners may have some, and they're very helpful to train for specific events and roles as well. So specific training requirements for outpatient healthcare providers, I've listed on this slide 24. So if you're a hospice, home health, PACE, or dialysis center, you must have specific staff training at least annually and document that staff training. Dialysis centers, of course, are required to maintain their staff competencies, but also document patient orientation to emergency preparedness. Now, certainly during 2017, the dialysis centers did a fabulous job in Florida meeting those requirements. It would be documented in the clinical record what to do and where to go if the center evacuated, who to contact if the center is unable to receive or return calls, and how to disconnect themselves from a dialysis machine if an emergency occurs. So the surveyor activities are very specific depending on you as an individual. They'll request to see your initial and annual emergency education programs. And for home health, they'll be looking for, and PACE as well, the individualized emergency plan both in the clinical record and in the patient's home. And that can be a problem for us because sometimes we do that on admission. We go over it with the patient and caregiver, and we leave it in the admission packet. And, of course, we can't find the admission packet when we go in the home. So that means that we have to keep a copy of that, keep that updated, and revisit that on a regular basis during our home visits. And we often have multidisciplines doing it. So if we have nursing, PT, maybe OT, and a home health aide going in and providing care for our home care patients or hospice or PACE beneficiaries, they're all updated on that individualized patient plan of care in the home, and they can reinforce those elements, such as, how many days of medication and supplies do I need? Where will I evacuate to if I'm in a mandatory evacuation zone, for example? What should I do with my pet? How do I get information if you're going to come and get me if your phones are down or my phones are down? What radio stations do I listen to, AM or FM? So all that would be in the individualized patient emergency plan in the home. What will surveyors look for, of course, on the training? Of course, first they're going to look for verifying your written training and testing programs that meet your requirements. Have they been done initially and annually? And when you've performed them annually, have you really updated those roles and responsibilities of all your staff that you're training? They'll interview, of course, staff and ask questions about the training. And if this happens, what would be your role or responsibility? And, of course, then they will be looking at staff personnel files to verify that initial and annual training and their understanding of the information is actually documented in their personnel files. So that testing is the second portion. So training was the first and testing is the second. So let's drill down on this a bit. Of course, we know that we must conduct that testing and exercising at least annually, and specifically one full-scale community exercise. And if you've contacted your partners and you're unable to participate in a community exercise, then you can have an individual provider exercise. You just have to have the documentation that you've made the calls to your partners and coalitions and an Office of Emergency Management, and that there wasn't a community drill for you to participate in. Sad to say that I've actually have many providers across the country, not in Florida, and I do have some providers in Florida, but we work in many states across the country, and I've had many providers call to be part of community-based exercises, and they haven't been allowed to be part of those exercises. Last week, that expert panel at HHS, the Esper Tracy group, did meet, and actually some of those barriers were discussed for this year and the upcoming year. So that'll be interesting to see how things change going forward. But as much as possible, you want to be part of a full-scale community exercise. There's really no definition to that. It depends on your location. It can be multi-jurisdictional and, of course, regional. And you will want to maintain documentation when you're participating in those exercises. So what is the required documentation? So providers need to demonstrate that they've contacted local, regional, state agencies and healthcare coalitions. So that contact list that I gave you in the communication plan, last week, is an example of that. Now, most of you have an electronic system for that, but you want the name and the 24/7 number, who you're calling and keeping them up to date on your patient population and your willingness to participate in community-based exercises. And, of course, on your council or coalition website, there's information on training and testing and exercises. So if you can't participate, then you will conduct an individual-based exercise, one that fully activates your emergency plan. And that way for you to do a 360 on what are your needs and your gaps and what do you need to do to minimize the event impact. So documentation is critical. In the CMS final rule, they do require that we maintain this documentation for at least 3 years, so they can review that on survey. Now, if you're part of an integrated system, of course, you can participate with an integrated. So many of you there are in a multi-hospital, multi-clinic, multi-center, and multi-home care agency system. You can participate with the system, but the training and testing needs to be specific for your regulations and standards. So that's built into your system plan. And an example then is that you would want to be testing training and testing based on your specific regulations. And so that's very clear. But you can be included in the healthcare system's community or facility drills as well. You'll just want to clearly document that, your response, and your analysis. So a quick reminder then is that an actual event that requires the activation of your emergency plan meets the annual full-scale community exercise. So I know in Florida with your tropical storms, and here we are in hurricane season, that many of you, of course, use those events as your community event. In the Northeast and in the Northwest, we use the ice storms and snowstorms as ours because we always have a full-scale event that we're called into, and that takes care of our community events. So the written documentation then will be your after-action reports, and that we want to drill down. That identifies the event, the response and analysis, your improvement plan, and your timeline for improvement actions. So let's look at that exercise planning and evaluation, and we appreciate all of those folks at the Department of Health, the coalitions, and our partners who really help plan or provide the planning for the exercises, because it's a lot of time and resources to do that. I gave you on that third tool that you have just the Homeland Security, of course, exercise and evaluation program. It's a 6-page document, but it's a good reference guide to look at the standard model. Now, it's not mandated, of course, but the planning, executing, and evaluation of an exercise is critical. And there are 5 phases for that. Of course, there's FEMA courses on that as well, and some of you have used the FEMA courses. What are the type of exercises that we have? There are discussion-based exercises, as you can see on this slide, or operation-based exercises, which are drills, functional, and full scale. So many of us are very familiar with the tabletop exercises and the full scale exercises or drills. And these are really a progressive approach to exercises, because the more complex that we get, the more time it takes to plan the event or the scenario. The cost and resources and complexity is compounding. But unfortunately, in this day and age, we understand that the more that we do for the details and the complexity in planning an exercise, the greater benefit that all of us have, all participants in that exercise, to identify our gaps and refine our program and really mitigate some of the risks that we have. So what works, of course, for the final rule then is drills. You know, the drill, if you activate your command center, that's the drill, your tabletop and functional exercises, and your full-scale exercises. Those are the ones that will qualify under the final rule. And tabletop exercises are really well defined. They're an informal, stress-free environment. We have found them very, very helpful when we have a diverse group of providers, inpatient and outpatient, who are participating in a tabletop exercise, as many or most of you have. We really learn from one another the tips and tools, not only from our peers in the same industry or the same type of agency, but across the table. And so it's really helpful to have mixed groups at these tabletop exercises and begin to look critically at what we can do and what we can do differently and how we can break down the silos to continue to work with one another. I think we have found in some of our exercises, certainly we've learned on communication plans, but staffing has been critical. We have actually been able to develop contracts for staffing with like entities for home care to home care and hospice to hospice, and staffing for some of our shelters and special needs shelters and other memorandums of understanding. We've learned from one another how to work with stakeholders as well as vendors. And so that's been very helpful. We've also learned when we've had to transfer patients, when we've had to evacuate or we didn't have staff, that we've been able to work with other agencies to provide staffing for our patient population. So the tabletop exercises and that informal, stress-free, just discussion of different case scenarios is really, really helpful. Of course, CMS has their definitions, and they require that it's led by a facilitator, somebody who's really well-versed and trained, and you all have those on the coalition, a clinically relevant emergency scenario, problem statements, of course, directed messages, and then certain timing of challenges is very, very helpful. It can be, of course, simulated scenario, computer simulated, or occur in an informal setting. But the interactive learning model is very helpful. Now, the full-scale exercises, of course, are defined by CMS as well. So for this requirement, it would be defined as an operation-based exercise or a drill that assesses your functional capabilities. So you're simulating that response to an emergency. Case scenario that many folks have used is that explosion 2 blocks down from the facility. So you've had a complete loss of utilities, interruption of transportation, your public uncertainty about the nature of the explosion, and the OEM may direct, or the police may direct, a lockdown for safety until further information is provided. So those scales are very helpful to identify gaps. They're time limited, of course. You will have goals and objectives. They're time limited, and it's very helpful, of course, to have an exercise planning team and a team in place when that occurs. So I listed those roles here, and they're also very clear in that support document that I gave you. But the team leader is the one who directs and coordinates that exercise, whether it's a tabletop or a functional. And, of course, you have a subject matter expert, that person who really helps develop the exercise and reviews plans and policies that need to be tested during. The logistics person to arrange for the resources for the exercise, and administrative support who really coordinate the schedules and register participants. It's a huge job, and we appreciate all of you who do that day in and day out for those of us in the community and in agencies. So the scope and objectives need to be very specific and clear. What are the indicators, the type of exercise, the duration and location, and what are the objectives in the framework? So being realistic, a plausible threat, and challenging is important. And so many of you drill so often. I would encourage you to look at when Asper Tracy and HHS met last week. Of course, some of you or all of you may be aware now, and on the Asper Tracy website, you can see that they're concerned now about the emergence of the Ebola outbreak in the Democratic Republic of Congo. And that's on their website, and they're actually registering now for a healthcare system readiness for highly pathogenic infectious diseases. And this is one that we recommend. You can go on the Asper Tracy website. That webinar, by the way, is Tuesday, June 12th from 1 to 2:15. You can register. There's still room available. There's also infectious disease resources and the Ebola topic collection there as well. They're very concerned about that, and also concerned about sometimes the lack of drilling or understanding exercises within a community or within an agency or healthcare system, what we would do if we had a communicable or an infectious disease. So that's a realistic, plausible threat that's very challenging to many of us, by the way. So I would encourage you to maybe consider that for this year if you haven't done that. But either way, go to the Asper Tracy website and look at the resources and consider being part of that webinar on June 12th. So again, just a reminder, if you have a question, don't hesitate to ask it in the chat box, and I certainly will answer it during the webinar if there's time. So the exercise personnel team I listed here for you. Many of us have been in many of these different roles, but I love to see when we do the health system, the full community emergencies and the exercises where we have the facilitators and the evaluators who observe and record, the observers and the controllers who are managing that exercise and the direct pace and ensuring safety, and then the actors who are very good about their specific roles, and we use many people for those actors as well. They make it realistic, and it brings right to the forefront what is my immediate responsibility and role during this emergency. So let's go back and then just recap. Exercise number 1 under the final rule is to be full-scale community, or if that's not available for you, then an individual facility or provider-based exercise, and document your attempts to be part of a community event if you haven't been. Of course, you can use a real event if that's occurred, such as a hurricane, that replaces that community-based event. And then, of course, exercise 2, that additional exercise on an annual basis will include either another full-scale exercise or community-based or tabletop exercise. And you have those opportunities in your region through the councils and coalitions. So I would urge you to go to their websites and look at that. Now, what do we do after the exercise? Of course, we're all familiar with the hot wash. What happens with the hot wash? It allows all of us as participants to provide immediate feedback, what worked and what didn't work for us. So that allows the controllers and evaluators to capture that immediate feedback. It also allows us to have a pulse of what's the level of satisfaction, what are our issues or concerns, and what are our proposed improvement items. So I would urge you to go to an after-action report. And the coalition website, that council website has an after-action report. In the second tool that I gave you was another Homeland Security sample after-action template report. That's very specific, but that hot wash is immediate discussion, immediate feedback of the test and the exercise. So we have a question here, and I'm trying to do a real quick review of the questions as we're talking. And so let me see if I can see that. We found, of course, during a hurricane, communication for provision of fuel was an issue. That is absolutely true. During an emergency, that fuel for your fleet or individual cars is going to be an ongoing emergency. So during an emergency, is there a liaison that could provide information or refueling locations? Is there going to be a scenario concerning this? And that's a great question. So, of course, if you have a fleet of cars, and I don't know how you operate your fleet of cars, but you might have contracts and memorandums of understanding with fuel providers. So, of course, we would recommend that you would be a priority. I know that fuel's a problem in every event that we have been in and to be refueling before, but what do you do with your fleet cars? Are they returned? If it's a planned, predictable event, of course, you want to be sure that everybody's fueled up, and that's very specific to their roles and responsibilities. But in the long-term events that you've had, and certainly that we've had in other regions, not just Florida, but without the power and without the fuel, how do you access the fuel that you need? So that's a good question. And I'm open to any feedback, other people that maybe could write in the chat box. If you have other suggestions, long-term loss of fuel, we can't get our staff out to in the field, what would be the recommendations for that? Where do we have refueling locations? But that would be an understanding for your fleet of cars and a contractual arrangement. Now, if there isn't power, of course, then your refueling contracts have to have a backup contract for a generator, and those refueling is often saved for emergency personnel. So if any of the folks that are participating on this have any ideas for this provider on refueling their fleet during long-term loss of power and lack of fuel for staff who are going into the field or traveling to shelters, that would be really helpful. That's a great question, and I will get back to you because I'll do some outside investigation if there are no other responses on this. Thanks for that question. So your after-action report, then, you want to look at what went well, what didn't go well, what was inadequate, such as your refueling, and how can you improve your plan? What can we do differently to fill the gap so that during a long-term power outage, how do we refuel our fleet of cars for our clinicians? So the after-action reports then are going to be very specific. What actually occurred, what went well, and what would you do different with timelines and improvement actions. And some of you, of course, put the responsible party. But that after-action template has those elements built in for you if you need that. And, of course, they're easy to get online. Now, the response for the fuel, so thank you for responding to that, would be to work with your local emergency management. So you have the contact numbers for that. As a provider, you want to contact them. You want to be in close contact with them anyway, before, during, and after the event. Particularly if it's a long-term, but be in contact with them and get those refueling options in line. So that's something that I would prepare for now. So to see what are the options that we have. Thank you for that response. I appreciate that. So once you complete your after-action reports, then you're going to look at what can you do differently and what resources do I need. Of course, depending on your entity, this after-action report will actually flow into your QAPI or your CQI or your quality improvement measures and your evaluation measures that go to your governing authority. So everyone's aware of that. That's performance improvement, but we all call it something different. And then you'll have very specific follow-up actions for the resources you need to do the revisions and training and updating based on that action report. So some 2018 exercise options, of course, and considerations. Now, I know that you all did a great job to identify the gaps. I know other than the refueling for clinicians and the communication gaps, and I do see your questions, so I appreciate them. You all need to take a step back and say, what can we do differently? And the after action report, of course, that's online, is very helpful. What are we going to do differently for our special needs or our vulnerable population? How can we anticipate our staffing during evacuations? Pre, during, and post-storm. And for some of us who use volunteers like PACE and hospice, how do we include them? What do we do for our supply chains? Supply chains, of course, need to be included in our exercise. So if you're going to do an infectious disease, our supplies for personal protective equipment, PPE, is in demand. We often have a shortage during those type of exercises. That's what we identify. What do we do for oxygen concentrators, regulators, and other equipment that needs power, for example, and medications? I know that we warehouse, we access, we have our patients go to shelters and bring a supply. Sometimes that 3 or 5 day supply is not enough. And so now we need to regroup on, does it need to be a 7-day or a 10-day supply? We had some issues, not only with over-the-counter medication and insulin, we had having issues with opioids now. And of course, that's an issue at the forefront. But for our hospice patients and our palliative care patients that are on opioids, having that medication or having access to that medication during and after event is critical. And so we've had during some events access for that medication has been a challenge for us as well. Another challenge has been home care and hospice contact information. How do we make sure we have updated home care agency provider information so that when patients return home, we can restaff? And in fact, under the final rule, home care and hospice are responsible to provide services in the shelter to their patients. So if they can't return home, where do we provide services and how do we communicate with one another and plan for that as well? We like to plan to cohort patients together in groups, and then our staffing is deployed geographically by cohorting patients and staffing. And sometimes we just do group staffing travel as well. So your 2018 exercise considerations, because you really want to be realistic and a challenge, your goals, how can you strengthen your entity, community readiness, of course, to care for that vulnerable community population and ensure continuity of care. So consider provider and coalition. What do we do for staffing and surge capacity? How do we access the Medical Reserve Corps? There are 65,000 volunteers on the Medical Reserve Corps. How does the message get out? How do we be part of that? How do we know what's going on? It is a volunteer, of course, but that remains critical in our community action plans. And what do we do for our supply chains, warehousing, and our housing options? Housing is a problem wherever we go, and returning to housing and having acceptable housing post-evacuation for flooding or lack of power remains a high priority. So having a backup scenario for that as well for our vulnerable population. So lastly, I would urge you to have an EP calendar. And that really will close the gaps. It will make it solid, a solid platform for your leadership team and staff to plan on, so that you develop this calendar, and right on the calendar is your annual HVA, your review, your training, and your testing. It really helps you demonstrate compliance. You become more predictable because you're really looking at the unpredictable events. On that EP compliance calendar, you would have team meetings, monthly or quarterly, for example. Your training and testing for new employees and onboarding, as well as your annual mandatory updates and your leadership updates. And then, of course, your exercise plans. So it's really helpful as an organization, whether you're a single agency with only 100 employees or you're multi-site, to have that EP plan and that calendar and update that on an annual basis. Bottom line for all providers, your initial training and your annual mandatory training is absolutely critical, so that they can demonstrate knowledge specific to their roles and responsibilities, and to be part of that exercising and training, so that, just like the book Blink says, that they know there's no hesitation, there's no slowed process. They know immediately what to put aside and prioritize in terms of their functioning for staff as well as patients and family members. Now, CMS, of course, will be surveying on the testing and exercising as well. And so I included a few examples of their questions that are built right into the interpretive guidelines. And they will want to review your exercise plan, and they'll also want to review your after-action reports. They'll check to see if you revised your plan and your policies based on your after-action report. And they're looking, of course, did you meet that full community exercise as well as that second exercise, which all healthcare providers need to meet. Just a few quick exercise tips then. Well, I hope that you've all gained one or two new things during this. And during this whole webinar series, that emergency preparedness takes time and resources and expertise. You have your coalition partners to rely on and contact for support during this testing and training. Be sure to reach out to them. There are so many resources available to you. So community partners are critical, and access to that specialized skill set for training and testing are very important as well. You want to have very specific after-action plans, and you want to be able to detail analysis and follow-up to improve your plans. Finally, crisis management is certainly evolving during this digital era. I saw a sign recently in a building during an exit, and it was in a stairwell, and it said, "Call 911 before tweeting." And I think that's an important message. In this real-time era, sometimes how people are doing hits tweeting and Facebooks before it hits you as leadership or an agency. Be proactive and innovative. Cultivate proactive crisis management. Plan to begin incorporating crisis care standards. Asper Tracy is looking at that now, and that's their plan for this year and next year. Bottom line, stay ahead of your risks and plan for the unpredictable. You want to be proactive to build trust and credibility and leadership. You all have worked so very, very hard. We appreciate you participating with this webinar series. Do not hesitate to contact me if you have any questions. Tricia, and it's on the first slide, rbc@netstep.net. Thanks, and have a great day.